Welcome to Distance is No Obstacle, the medical education podcast aimed at providing bite-sized education and information for doctors working in rural and remote Australia. Today we chat with Dr Tom Shannon, a urological surgeon at the Prostate Clinic. This is the first of two podcasts, and in this podcast, Dr Shannon discusses prostate cancer screening and treatment options. He's joined today by Dr Olga Ward.
Tom Shannon, welcome to the podcast.
Thanks for having me.
Tom, people often talk about men's health as if it's kind of all about prostate cancer. And I know GPs are always trying to get especially the male patients, to talk about heart disease and mental health at the same time. But men's health often needs a hook to get the blokes in the door and talk about anything to do with their health. Now they're not recommending us to population screen with a PSA, not to do digital rectal examination. So what kind of screening are we supposed to be offering to blokes?
Well, look, you've raised a lot of things there in our opening, so hopefully we'll get through all of them in our chat this evening. Look, I think the topic of men's health is really critical, and it needs to be a bit more all-encompassing, as you say. In fact, even though my practice is primarily prostate cancer and prostate disease, we actually do a lot of work with men's health because we realised many years ago there's not a lot of point fixing cancers to have men go off and have a heart attack. So we actually have a very holistic view of it. So if we get a chance, I can talk to you about how I approach men's health, and it's very much more applicable from a GP setting than it is in my practice, but it's been transformative for me in my practice, and the way men have engaged with the broader health message has actually been really good and really encouraging. And I know it's a very frustrating thing for a lot of GPs to try and get men to take responsibility for their health. So I've got the hook, I'll give it to you, but I'll probably just go back and answer on, what are we meant to do about the prostate? Why is it so confusing? And again, I think it's one of these things that has had a confusion that's been created. I think, unfortunately, unlike a lot of things in medicine, it's been a subject that's been clouded by a lot of emotions and one camp versus another camp. And that's really been unhelpful and unproductive for our patients. And I think we now have a situation where we've got a consensus guideline where we can come together. And it was identified probably 5 or 6 years ago by the then head of the Prostate Cancer Foundation that we had this schism between what one camp was doing and another camp was doing. And they said, well, look, we're doing as many PSA tests in Australia as we're doing mammograms. This question about whether we've got a screening program or not is irrelevant. Men are being tested. Why don't we do it properly? And why don't we figure out who's going to benefit, what the good bits and the bad bits are? And they started a process, went for about 2.5 years, and they came up with consensus guidelines, which are really straightforward. And that's where the dropping of the DRE came from. So it's almost 3 years old now, the consensus guidelines. There hasn't been a lot of education out in GP land about it, which is very frustrating for us. Because like it or not, you guys are at the coalface. The lack of a screening program, for the want of a better term, means that we don't have a centralised place where men go to get prostate checks. We don't have an independent service. It's a screening program by stealth that's being handed to you guys in general practice to do without guidance and also without setting of standards. In breast cancer, we've got pathology reporting standards, we've got radiology reporting standards, we've got none of that in prostate cancer. Different labs do different assays for PSAs. People report prostate MRIs without standardised setups. Pathologists report without standardised ways of doing it. So we're very behind on that front. But thankfully, GP land is fairly easy. Can I give you the summary of what we're meant to be doing?
Yes, that would be great.
Well, look, it's actually really straightforward. So what we do first is we think about men who are at average risk, which is, I guess, our notion of, this screening of asymptomatic men. It's really important to understand two reasons why we like to test. One is that prostate cancer really doesn't have any symptoms. So if it's an illness that we want to detect, we're going to have to go looking for it. And the second is the impact of the disease. I mean, it's the biggest cancer killer of men. We have more diagnoses of prostate cancer than breast cancer. It's a 1 in 5 lifetime risk. The impact of late detection is catastrophic, and the prostate's in a part of the body where we've got lots of critical structures near it. So we want to find these cancers early if we're going to be bothered to find them. So because of that, it does matter that we go looking for it in people with no symptoms. It's going to be a very long time before we develop symptoms from a prostate cancer. And in that group, the recommendation says in men at the age of 50 or over that we do a PSA test every 2 years. That's it. And by doing that, what we're doing, and what they've done probably different from other guidelines before, is that they've stretched it out to every 2 years. And the idea behind that is to try and reduce the risks of, say, over-detection or doing too many tests. But they omitted the DRE because they set the level for PSA at 3. And they also decided that they were worried that if you did a DRE and you found a lump, that would mean someone would have a biopsy. And so what they've tried to do with these guidelines is to get the balance as good as possible between detecting the cancers we need to detect and stopping men having procedures that they didn't need. What's really happened since those guidelines came out is MRI in a nutshell. And so men with lumps and bumps on their prostates aren't getting biopsies. In fact, we're doing probably half as many biopsies as we were 5 years ago, mainly because of MRI. So the natural process now is if someone's got an elevated PSA, they get an MRI first. And then the MRI is very good at showing whether there's a cancer that needs to be worried about. The trap with MRI, and the real trap, there's 2 big traps for GPs on MRI. One is that what we're relying on is actually the diffusion-weighted image part of the MRI sequence. It's called a multiparametric MRI, so it's not just anatomical pictures. And virtually every MRI machine out there can give you really nice anatomical pictures because they're set up for orthopedics or neuro. Yeah. What we need is this diffusion-weighted imaging, which is, if I can take 30 seconds to explain, it's about water moving around. We apply a strong magnetic field to water and we can move it. And the prostate, being a gland, has got most of its water is free inside ducts, inside a gland. Yeah. We've got rings of cells that have water trapped in it. That can't move, and we've got all this free water as well. So if you think about a cancer, we've got lots and lots of cells. Yeah. And so we've got lots more trapped water. So we can tell the difference between cancerous tissue and benign tissue. But in prostate cancer, you only get these sheets of cancer cells when the cancer is aggressive. So it's a great test if you're a bit older, if you've got other medical problems, where in those older guys, we only ever had to worry about the bad cancers. So it's been fantastic for older men because a lot of them are avoiding biopsies. And what's really good in older men is we really avoid diagnosing low-risk cancer in older men. And so that big group, the more common cancers, all of a sudden, we're just not finding low-risk cancers. And that's a great thing because that means they're not going to be tempted to have a treatment that they just don't need and be subject to the side effects. The flip side of that is because we only see bad cancers, then if the cancer's only moderate in risk, we might miss it on MRI. So younger men with 20 plus years life expectancy, for those guys, if they've got a high PSA or strong family history or other reason, I'm still going to biopsy them even if their MRI is normal.
Being rural, there aren't a lot of rural MRI scans.
And to be honest, if the MRI is not set up for doing a prostate, then it's probably not helpful because what you're trying to do is you're trying to avoid treating older men or you're trying to find cancers early in younger men. So it's a real issue. And obviously I get lots of patients who come up and see us and we streamline everything so that the MRI is done on the day they come and see me. So that makes it easy, but it's still displacing you. And we've really only got, for me, 3 machines in Perth that can do high quality MRI. But I think it's so transformative that if we're worried about prostate cancer, men should have access to it.
Sounds great. At least it gives us some kind of framework.
It does. So that's that average risk group.
Can you get any kind of useful image out of an ultrasound?
No, no, not at all. So we do transrectal ultrasounds when we do biopsies because it helps direct the biopsy. But in terms of saying, hey, there's this hypoechoic lesion or irregular edge to the prostate, then we're just not going to get what we want. And I know GPs order transabdominal ultrasounds to look. That's even worse. So, we've got high resolution rectal probes, and I don't rate them at all to find a cancer. Mm-hmm. So abdominal ultrasound probably has very little role for you in general practice, even in the management of LUTs. Because if you've got voiding symptoms, unless you've got hematuria, you want to look at your upper tracts, you really can't see the prostate or even estimate its size well with abdominal ultrasound. And what you often get is you get this protocol that's set up for women. So people go to their radiology practice, they're told to drink a litre of water and sit in the corner. Now, for women, it's no big deal, and we've got to fill their bladders up so you can see their ovaries with a transabdominal ultrasound. But with men, especially men with obstructive symptoms, you overstretch their bladders.
I was going to say a litre of water for some of my little old blokes would not be not be comfortable.
That's right. They get really distressed, and then they get the ultrasound and someone's pushing on their bladder, and then they're told to go and have a wee. They go and have a wee. They really struggle, and then they come back and they say, "Oh, you've got 250 mils left in your bladder," and they've been abnormally overdistended, and so then now everyone's worried that they've got severe outflow obstruction, and they end up getting referred to me, and then we do it under sort of more normal conditions and they're fine. So I really don't need people doing abdominal ultrasounds. It's tempting, but it's not going to help you. Can I just talk quickly about probably the other groups of patients that probably more important for you, especially in the country, to realise this, is that guideline of every 2 years starting at the age of 50 is for people of average risk. Yep. And if the PSA is above 3, you repeat the test. Mm-hmm. Now, Medicare hasn't caught up with that yet. I understand that's about to be signed off on, but you repeat the test and do it within the month. And if the PSA is still above 3, they need referral to a urologist. Yeah. So what about everybody else? I mean, what about people who are at higher risk, and how do you identify those? Because most of the bad cancers where people, get it when they're younger and they lose lots of years of life are actually in younger people, just like it is for breast cancer. Yeah. So prostate cancer is less common under the age of 50, but not with a positive family history. And if our lifetime risk is about 1 in 5 up to the age of 85, that's the Australian stat, you double or triple that risk by having a first-degree relative. Mm-hmm. And it's not much less if it's an uncle versus a father. Obviously, twin brother's pretty bad news, but once you start asking about family history, and a lot of men don't really know, but grandfather, father, brother, uncles, once you start asking, if there's a 1 in 5 out there, quite a lot of men have got a positive family history. And if those people had cancers at a younger age as well, their risk is really quite high. Yeah. So you want to start early. If we think about our aim for prostate cancer, which is detect the cancers that are important, so young is really important, and detect them early enough that they can keep their function afterwards.
So I've had a couple of patients who've been sort of, family history of prostate cancer in their 50s, and I've started screening them at 40. Is that about the age range?
That's perfect. And there's a lot of data out there that says if you do a PSA at 40, you can actually establish a long-term risk. So that's where you might see on your reports, you get the median PSA as well as as the 95% confidence interval, which is that normal range. Mm-hmm. So the reason they report median PSA is linked to future risk. So you probably notice if you look at it, the median PSA is super low, and it's even really low when you're in your 50s and 60s. And if you are in a higher percentile, then your long-term risk of prostate cancer is bigger than the average. So that's a good way of actually seeing who you might need to follow a bit more closely, and that's what I like to do with them. But if you start at the age of 40, you're probably setting a baseline reading. Most men at 40 will have a PSA of 0.1 or less. Yeah. If it's above about 0.3, there might be an increased risk, and if there's a positive family history, they're good people to watch on a regular basis, so once a year. And you were saying before about sort of engaging men in their health. I think it's a really good idea to try and get men to the GP at least once a year. The things you've highlighted that summarise mental health, we've got, men's health. Mental health is huge. The rates of suicide and depression in men who don't seek treatment especially is really high. We've got obesity, we've got diabetes, we've got poor alcohol behaviour, we've got smoking, and you've got all your regular things, your hypertension, all of those things, and cholesterols and so on. All of those things, they need to be monitored regularly to get on top of it. So for some men, the hook can be cancer. It can be a worry about cancer because there's a family history. I'm sure you notice yourself in your practice that patients are a lot more worried about cancer than they are about heart disease, when statistically that's nonsense. They really should be worried about heart disease.
It's always something useful to kind of take on board. Usually what will happen is they turn 50 and their wife propels them in for a checkup. And so you check as many jolly things as you possibly can.
Yes.
Skin check, blood pressure,
Yes.
blood sugar, all of that. And
Yes.
I would normally do a PSA until we were kind of discouraged from doing a screening PSA, but I've gone back to doing PSAs because I think it's helpful, even if it's normal, as you said, to have a baseline.
I think that the thing is with the PSA testing, there's never actually been evidence to say we shouldn't do it. Even in the US, which came out with the US Preventative Task Force came out with that negative, don't screen people over the age of 70, and then a couple of years later said don't test anybody. They've had, and we've had too, a major regression, if you like, and there's a lot of regret in the US over that directive. Prostate cancer is common and is not going away. We've got to sort the wheat from the chaff. We've got to find the stuff that needs treatment and find it early. The really important thing, as far as I'm concerned, is making sure that we don't treat men who don't need it, don't detect cancers that we don't need to find, but make sure we get the other ones and get them early enough. What's happening in reality is that everyone, I think, feels confused or feels like maybe they shouldn't be doing the test, and patients are asking for it, and there's lots of tests being done. And I see a lot of people who have abnormal tests and then don't get that acted on. It's very common that people have 2, 3, 4 abnormal PSAs before they get referred, as though it's a confirmation that there must really be a problem. PSAs 4, 7, 10, okay, I'll send it along. And all that is time. And time is not our friend in prostate cancer. So the amount of cancers that we detect at a PSA of 3 versus 10 is about the same. Yeah. All we're moving is the stage. So once we start increasing the stage of the cancer, the size of the cancer, that's where we start losing erectile function. Because it's not a bad news story anymore about erections and about continence, because we've got good treatments and good technology. And what's happened is that because the technology or the keyhole surgery is more difficult to do, you're finding there's less people doing it. So there's a consolidation of experience, and the results are just better. And rather than, it being the open prostatectomy was within the skill set of everybody and everyone did a little bit. It's quite different now.
Yeah. So tell me what's different, and tell me what hope I can give to my patients who are, as you say, extremely worried about erectile function, especially in their early 50s, when you sometimes find this, and the patients who are dreadfully worried about continence.
Well, look, I think a lot of things are different. I mean, I got interested in prostate cancer even when I was training because I felt like it was an area that was being neglected. I keep drawing the comparison between prostate and breast because I think in breast cancer they've set the benchmark for how things should be done. And if you look at how we do things in breast cancer with early detection and good support, good rehabilitation, reconstruction, all those sorts of things. So that's really what we try and do, is that we try through, I guess, things like this to educate people, to try and get people as early as possible. But with our individual men, when they come along, we get them on a prehabilitation program, and we've developed a weight loss program, which we're about to publish on, where just in 3 weeks we'll get over 7 kilos off people, and in bigger guys, we get 30, 40 kilos off them, which is life-changing. So if we look at what we're trying to achieve, again, coming back to that, the trifecta of cancer control, keeping your erections working and getting your water control back quickly, then there's more to it than just the operation, and it starts before. So we get these guys fit. We get weight off them. We get them fit. We look at their cardiovascular health risk factors. We even do cardiovascular risk screening, exercise stress tests, coronary CTs, all these sorts of things to try and make sure that they are not going to have complications and problems. And so they're in good shape, better shape when they come up to surgery. We in our practice, we have a physiotherapist and we have a dedicated nurse practitioner who work on the continence and the sexual health. So they've been working usually for 4 to 6 weeks on those, and they've got better erections than they've had for a long time, and they've got a good sense of how to do pelvic floor, and they've actually trained that muscle. Then we come along with the surgery, and the surgery, I think now it's pretty fair to say it's all keyhole. It probably should all be keyhole. I did my first keyhole but laparoscopic radical prostatectomy in 2004. Yeah. So it's not new. What we're getting out of the move to robotics is we're getting a very consistent operation for the men, because what's hard about prostate cancer surgery is that we're in the male pelvis. It's very hostile. It's not like the female pelvis, which is much more open and we can see things more easily. Often the anatomy in the male pelvis is really difficult, where the prostate's under the bone. And the big difference with keyhole surgery is that we're operating under 10 times magnification. And we've got these little instruments that are like your hand. They've got all the dexterity and the rotation of a wristed instrument. So it's very, very different from even what we were doing laparoscopically. And because you've got these tiny instruments, you can get into every little nook and cranny. So when we're doing the dissection, for example, we come in and we come through the bladder, but we're in the bladder when we're doing that part of the dissection. We come out behind and we're between the rectum and the prostate. Whereas when you're doing surgery open, you're just from the front. Yeah. A lot of things have to be done blind. You just can't physically see, and it's a deep, dark hole. So every single step under big magnification and great control. And the last thing we do is to take the nerves off. And although what the robot does with that dexterity and being able to come really close to where the action is, you're able to do really good nerve sparing to the point where you're keeping all of those erection nerves. You're able to do that without electrocautery. So there's no thermal injury, there's no diathermy injury, and we can do that because we've got this pneumoperitoneum, which is keeping the bleeding under control. And we're able to just gently push these nerves away. So at the end, it really looks like you've just plucked the prostate out. Mm-hmm. And that's great. And on top of that, with MRI, you've got a map. You've got a road map of the cancer. Yeah. So actually know the bits where you can come close and where you can go further apart. You
were talking about this being sort of more advanced, the way breast cancer surgery has advanced. Are you now doing lumpectomy in the prostate, or do you still have to take the whole prostate out if they've got a cancer in it?
Good question. So this is really what we call focal therapy. And as I explained to patients, there's 3 ways we can do focal therapy. We can cook it, we can freeze it, or we can zap it. It's been around for a while. And the problem that you face with focal therapy is that unlike breast cancer, you treat every cancer. All right, I'm not sure people realise that there's a lot of breast cancers that are taken out that were probably never going to hurt people. There's no such thing as watching a breast cancer. So they have a much bigger pool of operations they do on low-risk people. So our low-risk people we generally watch, and those would be the ones who'd be most suitable for the lumpectomy type procedure, for the zap, freeze or cook. And so MRIs come along and it can show us a discrete lesion, but those generally are going to be quite high grade. And what we haven't been able to prove is that people live as long with focal therapy And a lot of patients, 20, 30% of them, if you go back and biopsy them a year after focal therapy, they've still got cancer or they've got another cancer, because most prostate cancers are multifocal. Yeah. So the way I deal with that is that we really try not to treat cancers that don't need to be treated. But if they need to be treated, we decide whether they need a cure or they need control. If they need a cure, they get cured. You do an operation. If they need control, you've got other things we can use, like medication or radiotherapy.
Yeah. And speaking of medication, are we still sitting with the Zoladex implant type stuff?
So I avoid, this is ADT, and it's not just Zoladex. There's a few, Lucrin and Eligard, which you might see a bit more in the country because it comes in a 6-month prep. Another one called Firmagon, which is an agonist, not an antagonist. I avoid these drugs like the plague. I do everything I can to avoid putting people on ADT.
Because?
Okay. Globally, it affects quality of life significantly. And I think we used to think, when I was first a urologist, we saw a lot of advanced cancer in old men. And old men 20 years ago weren't around for very long. They were going to shuffle off and die. The average life expectancy for a 65-year-old in Australia is over 20 years. So most of our patients are living longer. And so we need to do better than just ADT. If someone's got 10 or more years of life expectancy, it's a different treatment. If they've got 3 or 4 years of life expectancy, ADT is fine. So once you put a man on androgen deprivation therapy, you will shut off his testosterone production. And less than 30% of men will recover their testosterone again. So we get these younger men who are sent off for radiotherapy, and a lot of them have low testosterone the rest of their lives. Mm-hmm. And the thing we know about testosterone now is it's really, really important for men as we age. To age in a healthy way, you've got to keep your muscle mass, you've got to keep your bone mass, you've got to keep your cognition. It's linked to depression, sleep changes, dementia, heart disease, losing muscle and becoming inactive and putting on fat increases our risk of diabetes, metabolic syndrome. There's trials underway at the moment where people with diabetes, I think you might have seen a couple of weeks ago was published, people with diabetes given testosterone was improving their diabetes. So now that we're dealing with chronic illness a lot more, and we're dealing with men who are going to live 10, 15 years, then I do everything I can to keep away from ADT, even to the point of trying not to use it with radiotherapy if we go down a radiotherapy path.
So you're aiming surgical cure and send the patient on their way?
Yeah, absolutely. Absolutely. And one of the other things that's changed a lot over the last few years, certainly in the big centres around the world, is even using surgery in the settings of metastatic disease. So converting this disease from a disease that's very difficult to control with a lot of local symptoms to something that's relatively straightforward to control, and that keeps men off ADT and chemo longer. So I guess that's an extreme example, but if we operate on people, there's a very, very low chance that they'll ever need ADT in their lives. Whereas if we give radiotherapy, most people get away with it for a few years, but if you've got a 10, 15-year life expectancy, there's a really good chance you're going to end up on ADT and chemo down the track. And the complicating thing with prostate cancer is not just one cancer. Every prostate has 8 to 10 cancers in it, of which some populations will be sensitive to ADT, some won't. So you will fail ADT, you will fail chemo, and if you live long enough, you'll probably fail radiotherapy as well. And then it becomes a very difficult disease to manage because we've got these populations of cells that aren't responsive to treatments. And that's why if you've got 10 plus years of life expectancy and you've got a curable cancer, even a resectable cancer, then that's what we're aiming to do.
And just getting back to the resection, open prostatectomy is something that's kind of laparoscopically assisted now?
So I've, as I said, I've been doing this for 20 years now, and I was a high volume open guy at the start. and then it became high volume lap, and now doing lots of robots. And so I've done them all, and I've done lots of all of them. And I can tell you very clearly that it's a different experience going through prostate cancer now than it ever was open. And open has hit the wall a long time ago in terms of progress and the difference that we can make with it. The problem with open surgery is that because you can't see, you can't deal with the variances during the operation, then we're less likely to cure the cancer, and we can't do the same things like the lymph node dissections in the same way. So the results just aren't as good. And there's really not a need to do open surgery. So everything we do, for more than 15 years now has been completely laparoscopic or robotic. It's all done with little cuts, all looking internally, big view on a TV screen and tiny instruments. And we can do very difficult cases that way because we've got really good control. So there's been, the last time I did an open prostatectomy was 2004. So it's just not necessary to do.
And are those available, like robotic surgery, I think only available in Perth?
Yeah. So.
And is that available through the public system at all?
It is now. So the availability of robots at the start was really quite poor, and there's still, I think overall the cost of doing things robotically, because you've got short hospital stays and it's more successful and so on, the cost overall is actually less or very competitive. So we now have one in Fiona Stanley as a public robot, which is a great addition for the public. We should have one north of the river as well, to be honest. And we've got robots in private hospitals at Hollywood, St John's, in Subiaco and Murdoch. So there's 4 robots in Perth. And for the size of our population, that's a pretty good number. It's probably, limitations probably the access to the robot in the public rather than whether they've got one or not.
Certainly for a younger man, it would be worthwhile, say, if a GP were referring a patient to actually mention that they thought that this might be most suitable for robotic surgery in the referral.
It's funny, when robotics first came out, it wasn't nearly as good as it is now, and the selling point was all around erections, because we know that's what men worry about. And I'll get back to a bit more about erections in a tick, but really what it's about is about everything. It's about doing better cancer surgery, better lymph node dissections, having less blood loss, less complications. Patients are staying in hospital 24 hours. It's a completely different game. So the erection side of things is very important for men, but it's by no means the only benefit of doing things with the keyhole surgery. The other side of if you look at erections on its own and prostate cancer, there's really actually 3 things that go into good erectile function after surgery. And these days, the most important thing is how good you are before, which comes back to vascular risk factors. So that's the most important thing. And so we work to maximise that before surgery. The second thing is how well we can nerve spare, and that's really determined by the stage of disease at presentation, which is that time factor we talked about.
Yeah.
So it doesn't matter to me whether it's a Gleason 10 or a Gleason 6. As long as it's not next to and invading those nerves, I can save those nerves. And the MRI has been great for that because, previously, before we had MRI, if you had Gleason 7 or above, people didn't really nerve spare, and that's more than... Yeah. They're all the ones you want to operate on. And then the third thing is the rehabilitation. So we know that if men are not getting erections regularly, they will lose function. And there's these changes that happen in the penis, both from vascular reactivity, which is why vascular health is so important for men. So men with poor vascular health who are losing erections in their 40s are your smoker, hypertensive, diabetic, overweight men. Mm-hmm. It's all because they don't have good vascular reactivity. And if you think about erections, most of the time the penis doesn't have much of a blood supply, and then all of a sudden it needs a huge blood supply, and then we block off the blood supply to keep the blood trapped. So erection is a vascular event. It's the canary in the coal mine for vascular disease. So if you're not getting regular erections, you're not getting this nutrition to the penis, which is a big sponge, and we get this microfibrosis, which is where shrinkage, bending, and erectile dysfunction comes from and becomes a permanent problem. So
some of the patients who've been diabetic vasculopaths for years do complain that, you know, my old fella's disappeared into my tummy.
That's
and I'm
right.
going, yep.
Or their tummies come out to meet it.
Their tummy definitely comes out to meet it.
So there's a chicken and egg there, but yeah, absolutely. And that's the message that we kind of get across. But if you want, the best thing that you can do for a man to improve their erectile function is actually all the stuff we want to be doing for men's health in general practice. And that's the carrot. So that's probably that good segue. But we get men back into having erections again pretty much as soon as the catheter comes out. So we don't want them to skip a beat. So if they can do that naturally, that's great. If they need medication, that's fine. We use vacuum pumps, injections of prostaglandins and vasodilators. We want them sexually active right from the start. So what I find is, especially now that I've got other people helping me, and I have this great nurse practitioner who's a country girl and very down to earth, the patients are just so much more relaxed. They just know that this is not a death sentence in any which way, and they're going to recover and function again. A lot of the anxiety out of prostate cancer goes. And my aim for my patients is that, you know, they're saying goodbye pretty quickly because they're fixed. They don't have cancer anymore. And we're so lucky in prostate cancer that we can do a PSA and tell you don't have it anymore. We don't have that in breast cancer.
Yeah.
Poor women find out 5 years later they've got metastatic disease. So for men, we've got that, and then they should get continent quickly, at least get it to a point where it's not restricting their activity very quickly, and then the erectile function. A lot of them are getting it back quickly and well, and they then don't need me anymore, which is great, and that's got to be our aim. But then that sort of leads us on to the next phase, which is how do we keep these men healthy for the rest of their lives? What's the point of screening them for prostate cancer, finding it early, fixing them, not doing too much damage, sending them on their way and they have a heart attack or a stroke?
Yeah, and I guess that's my job.
Yeah, absolutely it is. And you guys are given this sort of near impossible job of engaging the patients. So I
find that cancer focuses their minds very, very sharply.
It does.
And I think that's always a good stepping off point for GPs.
Well, what we did is that we were having this real struggle with obesity when we were doing this laparoscopically, because the instruments are only so long, and I have to hold and push these things. Robotics, the instruments are made for Americans, and you've got robot power, so obesity is not so much of an issue. It's one of the reasons why everyone's transitioned to it. But we thought about dealing with it the other way, where we were getting weight off people, and then we were noticing they were getting dizzy, so we had to stop their antihypertensives, and we were fixing their sugars, and they were actually following our guidelines for exercise, and in fact they were really motivated to exercise, and that became as big a part of the journey, which is what is really much more applicable for general practice. And then, so we've developed all these programs, but the program that I think's the good one for general practice is there's a talk that I give that I call Keep It Up. And that, for me, is men's health. And the Keep It Up is a very intentional double entendre, which is to try and motivate men in their 40s when they're still indestructible to look after themselves and make the right decisions so that they don't get erectile dysfunction.
And I think I have had this conversation with a farmer this afternoon.
Good.
So, Tom, thanks very much for joining us and for explaining so thoroughly about prostate cancer.
Thanks for having me.
Tom, on our next podcast, we'll discuss some more general urology issues that come up in general practice and no doubt in your practice.
Absolutely, looking forward to it.